the Chief Strategy Officer at Foundation Health Partners, and it is my pleasure to introduce to you tonight our dynamic trio of speakers. Mary Knight is an emergency department nurse at Fairbanks Memorial Hospital. She is a fan of using data to drive healthcare quality improvements, and she is a dog mushing enthusiast. Nellie Shortino is FMH's nurse educator for the ICU unit. She's described by her boss as, quote, a critical care neurology nerd who never stops learning. It's true. Nellie. And then Dawn Brefczynski is also a critical care nurse at FMH, and she has side passions for peonies and never sitting still. They have many years of emergent and critical care nursing. All three of these ladies are passionate about early stroke recognition and treatment, and they are committed to improving the health literacy of our community around this issue so that we are better able to swiftly identify symptoms of stroke. They were nationally recognized recently in Houston at a nursing conference for the development of the BEFAST program, which is what they're going to talk about tonight. I am very proud to have you speak. Right. Here is Dawn, Mary, and Nellie.
Has anybody been to any of the community lectures that Dawn and I have given on BEFAST? I knew you, did you go to Go Red? Go Red, okay. So we've been purposefully getting out over the last year, and so just spiel before I forget it. If you belong to any community groups and you like the lecture and you think it would help your group, our emails are at the end, or you can always contact the hospital and just ask for me. They'll get the phone call to me, and we are happy to come to anywhere, whether it's, we've spoken at the Rotary, at Go Red, at Fairbanks Over 50. We're open to church groups. We truly are passionate on the subject. Okay. All right, so we started a long journey in Fairbanks in 2017 to improve the care for stroke patients given at the hospital, which rapidly became what we really need to do is get community to understand how to recognize stroke symptoms. We spent a year educating all of the nursing staff and really working on our processes. And then from there, we taught every staff member, be it from janitorial staff all the way up to the administration guys. And then we started branching out into the community. So as we go through, you'll learn a lot about stroke, and we are open to any questions. So you don't have to wait until the end. Just speak up and we'll come out, okay? Do you have the, I have the clicker. Turn it on. Sorry, guys. All right.
So stroke is a condition that is pretty common in the U.S. Every 40 seconds, someone in our country has a stroke. And there's a massive number of deaths per year, 1 every 4 minutes. But more importantly, and kind of more relevant to that, is that 7 million people survive strokes. And unlike conditions like a heart attack, where you have your heart attack, and if you get to the hospital in time and get treatment, you're kind of can roll back into your life. Surviving a stroke often leaves you with permanent disability, permanent things that you can't do. You can't go back to the life that you necessarily had before, even with significant rehabilitation. And so that kind of survival factor and the fact that it is so common, so many folks know people from family, friends who have suffered from strokes, that it becomes really important to recognize its prevalence, but also recognize how to recognize it, because the nice thing about stroke is that it is treatable if you can get to help in time.
And you see the very bottom line, 80% of all strokes are considered preventable. So we're going to talk about, you know, there are things that you can do to prevent, and then there are those things that are non-modifiable that are genetic related. But 80% are preventable if we just can educate everyone in the community on how to recognize. So as Mary said, 2/3 of survivors live with disability. The thing that is really scary about stroke is that 25% of people have another stroke in 5 years. So now in different strokes, depending on the blood flow and where the stroke impacts the brain, you can have very, very different symptoms. So someone that has 2 strokes could have double whammy on how it's impacted their life. And then healthcare costs are through the roof, but to me as a nurse, that's never been my focus. My focus is on the health of you guys.
And the piece about the kind of longer term outcomes from stroke, and the reason, the human cost that I think about too, especially being active, being Alaskans as we are, we're up here for a reason, we've stayed up here for a reason, and most of that reason is outdoors. It's activity, it's the things that we want to do to get out, whether it's dog mushing, whether it's harvesting peonies, whether it's sitting next to the fire in the winter, knitting blankets and crocheting for friends and family. It's all these things that we do with our bodies that make us want to live up here in this beautiful place and be out in this beautiful place. And surviving a stroke then sometimes can lead to not being able to participate in those things again or anymore without significant changes. And so it's another reason to really be on top of both recognizing it and also knowing what you can do for yourself to prevent a stroke from happening to you or your loved ones as well.
So those were statistics to the United States as a whole. But look at some of the statistics from Alaska. And Mary and I take part in a coalition we'll talk about later on that's an Alaskan coalition looking at what can we do to help prevent stroke and help give better rehab options for people that do have strokes. So average age of stroke in the United States, most of the United States 70. In Alaska it was 66 and now it's down to 64. And I don't know about you guys, but 64 seems darn young to me to want to be incredibly impacted. We have a disproportionate amount of strokes in our Alaskan natives, and so we're always looking at the risk factors and the whys of that. And then the last, Alaskan patients 18 to 45, the risk of, well, actually having a stroke increased from 5% to 17% in young people. I mean, if you think, like me, 64 is young, what do you think about the 18-year-old that has a stroke? And so we really have to drill down and work on preventables, but also early recognition. All right, before I start going into what stroke is, you see Don hanging over the side and everybody sees we got a table setting up here. I would like 2 volunteers. Any 2? Come on up, come on up. Thank you, ladies. Okay, so what these guys are going to do, and we purposefully put them so that you can all watch. So it's fine for me to tell you a stroke can impact you by X, right? But what you're going to see is people doing something as basic as tracing and painting as if they've had a stroke. They have to use their non-dominant hand. And they get to wear these cute little glasses that impact the vision. And so it becomes even harder to see, okay? And you guys can watch. And I know, it's horrible, isn't it? And remember, non-dominant hand, so if you have to sit on your right hand, do that. You can use your elbow to kind of hold because a lot of people with stroke do maintain some shoulder movement, but it's everything else left hand, and you'll see how hard it is. Oh, sorry. All right. So who feels like they know what stroke is? What do you think?
It's a lack of blood to an area of the brain.
Okay. What causes it?
Well, plaque build up.
It can be a blood clot. It can be plaque breaking off and going up to the brain. It can be a lot of things. But we have major vessels that feed our brain just like we have major vessels that feed our heart. Most people, if I ask them what a heart attack is, they can tell me pretty well. But stroke is just as devastating. And as society, we just don't understand the causes quite as well. So that's one of our challenges. Everybody, if someone says, oh my gosh, I'm having chest pain, everybody knows immediately, say, take them to the emergency room, right? But can you recognize the signs of stroke? So stroke at its most basic is just when blood flow is interrupted to the brain, and then those brain cells are starved of oxygen. So you will hear us say a lot that time is brain. Dr. Honorato, our local neurologist, really says time is brain, save the penumbra. So when you have blockage go up and interfere with the blood flow to the brain, you're going to have some immediate death because of lack of oxygen, and it's very localized. What we're trying to do is save all the area around it. So if you look here, this dark spot is what immediately died at pretty much the first very short amount of time from the stroke. But do you see all the lighter color? That's all brain tissue that we can save, help you save if you get treatment in time. So someone mentioned mini strokes earlier. I hate the name, and please tag me when you're ready to talk. I will. I hate that we call them mini strokes. They're actually warning signs. So TIAs are incredibly important to pay attention to. Trans-ischemic attack is the medical terminology. Most people will say TIA or mini stroke. It is a warning sign, and it's a warning sign for a big stroke, okay? So if you have symptoms, and again, Alaskans,
Yep, Alaskans tend to ignore their symptoms because unlike, we all know heart attack, chest pain, go to the hospital immediately. The signs and symptoms of stroke that we'll talk about later are often things that we kind of want to ignore, that we're going to try to sleep off, that we're going to maybe have a nap and it'll go away a little bit later. And every minute that you don't go seek help because it doesn't seem that urgent, because we're stubborn and we like to take care of ourselves and we think it'll be fine, is another little piece of that penumbra that's going to die permanently and be irreversible. And so the urgency of this is figuring that or learning that and kind of driving that home so that when you recognize these things, you don't just shrug it off like stubborn Alaskans that just want to be fine and go. Because, and the thing about the transient ischemic attacks especially is that they are a warning sign, but a lot of times because they go away, the next time it happens, somebody will say, well, you know, I got a little dizzy and I went to sleep and I woke up and I was fine, but the next time you're not going to be fine because that warning sign, that it kind of gave you a false sense of security that those symptoms would go away, and you didn't go in to get evaluated, or you didn't urge your family member to go in to get evaluated and get on some of the preventative things that we can do for folks when you have these shots across the bow that a big stroke is impending. And we'll talk more too about how that kind of the Alaskan stubbornness, just like we like to be outside, we like to take care of ourselves and be independent, is potentially affecting some of those earlier statistics about Alaskans and their stroke numbers.
And you hear us keep harping on stubborn Alaskans. The reason we say that is because guess what we all hear from our patients that waited 24, 48 hours, that had symptoms in Healy and decided, oh, I'm just going to drive to Fairbanks. Had a patient, honest to goodness, in a plane, started having stroke symptoms, knew he was having stroke symptoms, decided to land the plane, hop in his car, drive from Glen Allen to Fairbanks. He was very fortunate he didn't hurt someone else on the road, but very unfortunate in that by the time that delay meant we could not offer him any reversal or treatment. So then the devastation stayed. So I know you're going to hear us keep harping on this, but it's because we hear it from you guys. Yes, ma'am.
On this topic, could you explain what Fairbanks Memorial Hospital can do when we get to the emergency room and how long it's going to take?
It's a really good question. And Mary is our emergency room nurse, and we have that in our slide. It comes kind of towards the end. We were going to talk about stroke and recognition and finish it up with
with
Treatment.
that. So if I will go through the whole process of what happens when we get to the hospital, and then if you have any further questions, then spit them out then. But yes, yeah,
Absolutely.
Yep.
Absolutely. One other thing about TIAs, it says that symptoms can resolve in as few as 5 minutes. We consider it a trans-ischemic attack if all of your symptoms have resolved within 24 hours. Okay? So the symptoms can last that long. All right. 15% of all strokes occur after a TIA. That sounds like a low number, but remember that they tend to be devastating if you've had the warning signs. And even if your symptoms resolve, I always say call 911. And I got to tell you, I drive this home with my parents too. And here's why. Everybody wants to hop in a car and they want to drive themselves to the emergency room. Okay? Or they want their significant other to drive them to the emergency room. So I got two things to say about that. If you're on the road and you become disabled and you lose control of your car and you run headlong into a car full of a bunch of local kids, like how devastating would that be to live with? So don't drive yourself, absolutely not. And as far as having your spouse or significant other, if you get worse, you're putting them in the position of having to decide, do I pull off and try to do emergency care, or do I keep driving while I'm terribly upset? And so it's hard on yourself, the community, and others. So I'm a big proponent of please call 911.
And the reason that we ask you to come in to the emergency room is just as there are many types of strokes, there's clots, there's spasms in your vessels, there's hemorrhages when the vessels burst. If we can narrow down kind of what your risk factors are, sign you up for some, or get you in kind of more quickly to be evaluated for some of those risk factors that we can do something about, that can prevent that stroke from happening later. And so that's why we want you to urgently get in, be evaluated, and get those follow-ups set up more quickly through the emergency department.
All right, so we keep talking about risk factors. You have modifiable and you have non-modifiable. And for Dawn, the risk factors are on the handout, right? Everybody can get a handout on their way out if you haven't already got one, and it's a one-page that kind of summarizes 45 minutes worth of talking from us. So non-modifiable, we cannot change our age. We cannot change the fact that we are female, and we cannot change our race or ethnicity. What we can do is take some of these modifiables, know that you're at risk for that, and know what to do about it. High blood pressure being the number one thing. And so for people that don't want to keep their blood pressure under control, you're being very hard on the blood vessels in your body, which puts you at risk for stroke, but also other big concerns. So get your blood pressure under control.
And for the blood pressure as well, I would say one of the nicknames that we have for blood pressure is the silent killer, because it's something that you can have incredibly high blood pressure just normally and not realize it if you're not going into the doctor to get checked, if you don't have a way to, I know they've got those blood pressure check machines at a lot of the grocery stores, but knowing what your blood pressure is, if you're somebody who goes to the doctor once a year or maybe doesn't go to the doctor unless you're actually sick, you can have high blood pressure and not realize it for years and years, and all that damage is being done. So it's definitely something to check in with, even if it's just on your own, and see what those numbers are, and check in with your doctor to get on some medication. There's so many ways to control high blood pressure these days, pills that have not a lot of side effects, and it's an easy thing to fix and control, and prevents huge consequences down the line between stroke, between heart attack, lots of other issues that come from that. So that's a huge one.
And I will say, like, for my mom, if any of you guys are out here like her, she had, women tend to have diastolic hypertension. That bottom number starts creeping up way too high. And the doctor said, okay, I'm gonna put you on a medicine. And she said, oh, okay, is there anything I can do to not have to take that medicine? And he said, absolutely. She carried just a little bit of weight right in her tummy, like we tend to do as we get older. And he said, I want you to start walking and get up to walking 3 miles a day, and then we'll recheck in 6 months. Now, that bottom number is her indicator that she has not been walking enough, because that took care of it. She's not on a pill as long as she stays on her walking. But if she goes off her walking, then she has to go back on the medicine. Some other things, smoking, and I'm glad we no longer say tobacco. It's truly smoking of any type, anything that you're inhaling into your lungs. Diabetes, and by diabetes I mean poorly controlled diabetes. Absolutely. Migraines, if you've been a migraine person your entire life, you're at much higher risk for stroke. Sleep apnea, just like high blood pressure is a silent killer, it's disturbing the number of us that have sleep apnea that don't know about it. You don't have to have a big neck, you don't have to have huge snoring, you can be kind of a silent sleep apnea person. Alcohol or drug abuse, poor diet, poor exercise, high cholesterol. Atrial fibrillation is a huge risk factor, and I say that if you don't take the medicines that the doctor puts you on. So if you have atrial fibrillation, they will usually put you on some form of blood thinner, which actually takes most of your risk factors away. All right, so then what can you do to beat all of that? You treat the things that you're at risk for. And you guys know yourself better than your doctor will ever know you. So if you're a couch potato, get off the couch. If you like McDonald's, look for some healthier eating. If you're pretty active and you eat a pretty good diet and you still have some of those risk factors, that's when you absolutely want to talk to your doc.
And
I didn't talk about stress. Yeah. Stress is a hard one.
Huge. Yeah.
Stress is hard on all of us. And I hope a lot of you guys have had the joy of retiring. Has anybody retired in the audience? Did your stress go up or down when you retired? It went down? Down? Excellent. Some people find stress actually go up when they retire, and those are the ones that I really stress. Let's get you up and moving and do things that can help lower stress. So some numbers, and I will tell you, everybody's going to look and they're going to see the red and they're going to say, oh my gosh. And Dr. Ombrellaro, who I heard a few of you guys saw in a talk last week, actually gave us a different perspective, which I was very happy to hear. So in 2018, we had 73 strokes come into our emergency room, went up to 112. In 2020, that was the year of COVID hitting. No one came to the hospital unless they were absolutely dying, like everybody stayed away from the hospital. So we saw a huge decrease, and then every year since then, we've seen this trending up. And so as nurses, we all focused on the, oh my gosh, what are we missing? How do we teach? What do we need to do? Because this is alarming. We're having more people having strokes. Dr. Ombrellaro said, you got to look at statistics. You were under-treating before, meaning people were having strokes and staying home and never coming into the hospital, so they were never in our numbers. And since we've been going out into the community and raising awareness, we're starting to see more strokes treated at the hospital. So that's actually a good thing. So can I say for sure which way it is? No, but I like Dr. Ombrellaro's spiel better, so that's the one I'm going to go with.
Something that I have looked at, I was, like, as they said, to look at data quite a bit. And one of the pieces that I looked at in 2022 especially was how long it was, as we were starting to do more community education, how long it was taking people to reach the hospital. So coming towards what you were asking about in terms of what we do at FMH when somebody shows up with a stroke, we can't start treating until you get there. And there are a couple of specific time windows for different treatments where we can treat a stroke with one thing in a small time window. There's a second treatment depending on the type of stroke in a larger time window. But the longer you wait to come to the hospital, the less time we have, and you may miss out on some of those opportunities. And when I went and looked at the number of these patients that are coming into FMH, 67% that came in for stroke arrived outside that window. And that window, for the specific window that this one is talking about, is that initial window for the most kind of immediate and dramatic treatment that we can give. And that's, you need to get to the hospital within 3.5 hours of the beginning of your symptoms, when you first noticed your symptoms. So you have this 3.5 hour window to get to FMH. 67% of our stroke patients were ineligible for that treatment because they didn't get there in time. So another reason for us really pushing this recognition and the urgency to get into the hospital.
What is
The treatment is tenecteplase. It's a clot-busting medication, but it can only be given within a 4.5-hour time frame, and we need an hour to ensure that it's safe for you to take that medication. So that's why we have that 3.5-hour arrival window.
Yeah, and what they found is in very large cities, they've even tried giving this medicine out longer and longer, and it's just not as effective. So it increases your risk from receiving the medicine, and it's not as effective. And so that's kind of where they came to this time window. Treatment eligible patients were arriving, the majority, within 37 minutes of that cutoff window. 37 minutes that meant they waited just that much too long to get in to be able to receive the medicine that could have really blocked off, just knocked out most of those long-term effects of stroke.
And as far as the treatment eligible patients, they arrived really close to the cutoff, and we were still able to potentially give them that treatment. But the thing about the treatment is that the earlier you give it, the more effective it is. And 90% the effects of the stroke can sometimes be up to 90% reversed if you get there within that first hour. And after that hour, how effective the medicine is drops off very quickly.
So I have a question. So as you guys mentioned at the beginning, a lot of us like to be outdoors and fishing and doing whatever. And so you mentioned at the beginning there was somebody who was near Glen Allen, right? So what is this person supposed to do? Do they have facilities in Glen Allen or what? Can you talk about that?
Yeah. So there are clinics, and a lot of the small towns will have a clinic and a 911 service. And those 911 services, if you call 911 in Glen Allen, it's often a volunteer ambulance service, but they have the capability to call a medevac plane in and get you to either Anchorage or Fairbanks within an hour or two, depending on when your symptoms started and when you could get to them. But it's always, there are many possibilities for medevac, even from some of those places. If you're out backpacking in the Brooks Range, there's not much anybody can do for you, but at that point, besides what you could do with the resources you have on hand. But if you're near a community, and especially on the road system or somewhere near an airstrip, they can often get these medevac flights in.
Do the EMTs have medication on board? Or do you have to show up at the facility, at the hospital emergency room?
You do, yes. The trick with I'll just go ahead and talk a little bit about that initial treatment since we're talking about the timing, just to give a little more context. So tenecteplase is the medication that we're currently using as the clot buster for stroke. That medication, because it basically thins your blood, makes it so that it can't clot and it breaks up clots that are there. It also makes you very prone to bleeding. But a certain percentage of strokes are happening because your brain is already bleeding. It's not a block, but it's because of that bleeding. If you give someone who's having a hemorrhagic stroke or a bleeding stroke that clot busting medication, you will kill them. And so until you get a CT scan of the brain to ensure that that bleeding is not happening, it's totally not worth the risk benefit to give them that medication, and that's why that's not available on ambulances. And so the best thing, the part of the reason for calling the ambulance, and this question has come up as well, is that even though they can't give you the medication, if you deteriorate and you're losing your ability potentially to breathe or other things, the EMTs can keep those things going to get you to the hospital so that we can treat you with the tenecteplase. And so that's another reason to call the ambulance as well.
They also call ahead. So you're met at the door, right? Like the CT scanner's already cleared, everything's done. But in addition to that bleed, you're at risk of bleed just from taking this medicine, which the doctor talks about with the patient and the family. If you, again, go back to that high blood pressure being that #1 risk factor, right? And I said it's very hard on the vessels. If you have an area of vessel that's weakened that we can't see on CT, then you can start bleeding and you need to be in an intensive care unit where we can treat it immediately. And so it's just not a safe medicine to be able to give outside of outside of a hospital setting.
I think you answered my question. So you need the CT, and it's not standing order, the clot buster. That's not a standing order.
It's not a standing order for the
doctor,
EMS.
Get the CT staff in, and that's really hard to do in Fairbanks, Alaska. I used to work ER.
It's not anymore. Since
not?
we have, since 2017, the stroke committee at the hospital has done a tremendous amount of work, which is what we spoke at nationally, was how we went from where we were to the capabilities and the treatment plan and the process that we have now. And it was getting everybody on the same page, and it's educating everyone throughout the entire facility. And we'll talk a little bit more about that. Did I get everybody that had raised their hand? Okay. So, all of that to say, if you do nothing else, if you remember nothing else from this speech, I want everybody walking out remembering BEFAST. There's magnets at the back that Dawn made so that you can put it on your refrigerator. And I'm going to go through each letter. I can tell you, since we started teaching this, there have been so many people, hospital staff as well as friends and family, who have said that just knowing this, they were able to help save someone else. So haven't had anybody say, I recognized a stroke in myself, but I've had more than I can count on two hands say, I was able to recognize and immediately get care for, and then fill in the blank, because it can truly be anybody. It can be somebody that you see at the grocery store, it can be a grandparent, it can be a child. Remember that we can see stroke in younger ages. So does anybody know the BEFAST acronym? All right. So B stands for balance, okay? So balance and dizziness. And what I need you to remember is sudden change in. You're going to hear me say it 1,000,000 times over the course of the next 5 minutes. It's not the person that had difficulty with their balance for the last 3 months. It's that you normally walk fine and you're walking along and now you either lose your balance or you trend to one side, or you're getting super dizzy, not just when you stand up, that can be something else. But if it's a new onset balance problem or dizziness, then that can be a sign of stroke. And so what you're going to do is you're watching out for people. Dizziness is really hard. It really is. It's an indication of a posterior stroke, the blood vessel in the back of the brain. And there are so many things that can cause dizziness, but it truly is sudden change. It's not something that happened over time. So for E, eyes and vision trouble. So with that, you can have, and now you can fill in the blank. It can be double vision. It can be like our people up here who had been drawing, where you can see vision is, that's called quadrantenopia, where 1/4 of each eye, you lose the vision in that. You can lose vision in just one eye. You can have photophobia, or extreme sensitivity to light that's very sudden. And so you're just listening for anyone around you saying they're suddenly having difficulty seeing out of one or part of both eyes. This is the part that most people recognize as stroke symptoms. So F stands for face. And so this can be loss of sensation or loss of motor control, okay, on one side of the face. So all of a sudden you've gone numb. It feels like you've gone to the dentist. What we see more frequently is this drooping on one side of the face. So what you do is you ask them if they can smile. Can they show you your teeth? Okay? And what you're looking for, oh, you hold this for me.
Yes.
We all have these lines right here, right? Fancy name is nasolabial folds. So when I say smile, look to see how many teeth you see on both sides. That's one way. You're also looking for a flattening. Do you see what happened when I smile? Right here? No, maybe? Okay. It's hard to see across the room. It's a flattening on one side. Even if they can smile and show all their teeth, do they have a flattening of this line? And that can be a sign of stroke. Everybody knows the arms. Everybody thinks of a stroke as all of a sudden they can't move one side of the body. So with arms, it's arm and leg. Remember, it can be sensation or motor, so feeling or movement. It can be something as dramatic as this arm is now completely limp and I can't do anything with it. It can be all of a sudden you try to pick up the coffee cup and you don't have a grip, okay? So it can truly be either, but it's unilateral, one side of the body, difficulty moving, or sudden weakness. So what we do at the hospital is we ask you to hold up both arms and we watch for one arm drifting, even if it's just drifting a little bit, okay? So S is speech, and remember that we have speech that we're speaking, but we have the brain that is hearing someone else's speech and interpreting it and making it make sense to you. So it's not just difficulty speaking. Sometimes it's called receptive aphasia. Sometimes all of a sudden you can't understand what is being said to you. So look for the person that all of a sudden is very confused and saying, "What? I don't understand you." That is a sign of a stroke. And one of the things that you can ask them to say is, "You can't teach old dogs new tricks," because we're really making the tongue do a lot of movement, okay? And then T is for time. Time is brain, save the penumbra. And so if anyone has sudden trouble walking, balance issues, dizziness, vision changes, facial drooping, weakness on the arm and leg, difficulty speaking or understanding, remember Mary saying 37 minutes, that's where we're missing it, that's where we need to tighten up as a community and get people in faster. And so you would dial 911. Now, we're going to talk about the treatment plan.
I just have one question about all of these different signs, okay? A few months ago, maybe half a year ago, there was a particular individual who was a senator, and he was giving a talk, and he just stopped for several minutes.
Mm-hmm.
And if I was standing right next to him, what should I have done?
You should have told him you're concerned he's having a stroke and that he needs to be seen by his doctor right away.
Okay.
Or call 911. It's really hard whenever it's someone that is not your loved one to call 911, because then they might not get in the ambulance, and then they're mad at you because you called 911. I do it anyway. I'm okay if somebody's mad at me. But yes, anytime you see someone with that delayed inability to speak, I would have been concerned and told them they needed to be checked out.
Yep. We have one more question, and then we can ask them how they.
So you're looking for any of those, not all of those?
Yes, any of those, any one. Yep.
Anyone.
Any one of those.
And sudden being the operative word.
Sudden is the operative word. And the reason that it's any one is we have blood vessels that go up either side, different blood flow. Okay, so you got a right and left that goes to the front part of the brain. This tends to be problems with personality. Okay, middle part of the brain, the vast majority of strokes, it's just because of convenience, it goes straight up. And that is where we see problems with speech, problems with vision, problems with arm, leg. Okay, and then you have the back side of the brain, completely different blood flow that comes up through here, and that's where you see the double vision, the loss of balance. So depending on where it's affected and how small the clot is, the further it can get into the brain before it clots off, sometimes the less symptoms you see. It's really good questions. Do you guys want to talk real quick before Mary starts talking about how was that? Painting.
So, it's because I didn't care what was happening, painting was okay.
You can show
But-
everybody your pictures.
Yeah, so I thought the most difficult part was blocking my eyes. I mean, it gave me a headache, you know. I had a hard time, you know, it's like, wait a minute, I want to see your slides and I can't see them and I can't see people. And so I found the blocking of as long as I was looking down, it was okay.
So you were cheating.
Well, she didn't tell me I couldn't look down, but it's like, if you look below the glasses, it's okay. But if you look straight up, it was, you know, you see half a face, you know.
Yeah.
Very
But,
frustrating.
yeah,
For me,
so
it was
there
the
we go.
adjusting of my head so I could see. So it was like, would somebody who was having vision problems,
You can't adjust that out.
but you know what I mean, would you be trying? Because if I can't see out this side of my head, then I'm gonna turn this way so I can see.
You do, which is why when we have someone with a stroke, we actually tend to hand them the paper that we're asking them to read so they can get it into that part of their vision and actually be able to read it. Yeah, it's really difficult, isn't it?
Yeah.
Yep.
Thank you, you guys.
You guys did a great job. Thank you so much. All right, so now it's Mary's show.
I'm going to talk a little bit about kind of what happens in the time that after you make that 911 call and the ambulance is on the way or arrived, up through kind of what happens in the emergency department. And the things that you can do right now, if you're with someone that you know or love, information that you can gather that's going to help speed up our process and get our time down to get that medication in sooner. The biggest and most important piece of information is to find out if you didn't witness the person's change in its symptoms or the onset of those symptoms, find somebody who saw them when they were last normal. Or if they were asleep and woke up, find out exactly what time they think they went to sleep. When did their naps start? Because that was the last time that they were known to be well, and that's kind of when the clock starts for that 3.5 hours. And for a second treatment that I'll talk about, there's a 24-hour window for that second one for certain types of strokes. Knowing that is really important. And as we know in all of our jobs and all of our lives, communication is one of the hardest things that humans have trouble with. And communicating, making sure that that information about exactly when that last known well time was, who saw them last well, what time was it, gets communicated very clearly to the EMTs so that it will get communicated to the doctors and everyone else down the line. So finding that information out is very critical. When you come into the hospital, if you come in by ambulance, that's another reason to call. Again, we mentioned it a bit, but another reason to call the ambulance is that all of the EMTs and paramedics in the state are trained in this exact same BEFAST acronym. They go through those symptoms, and if they believe that you're having a stroke, they will get that information and some other medical information that's going to help, again, speed up our process once they get to the hospital and cut down every minute that we can cut out of that time is going to make your outcome better. And so they're going to get that information, they're going to call ahead and let us know, and they're going to let us know about when they think they're getting to the hospital, and we're going to have a room cleared for them, we're going to have the CT scanner cleared and ready for them to go on the table as soon as possible, and cut every minute down that we can with that information. So another reason, again, to call 911.
One of the huge changes, to your question earlier, one of the huge changes that has come about from all of this work is that you don't get admitted to the ER. If you come in with stroke symptoms, you're bypassing everything. So we don't stop and do paperwork. You get a very brief neuro exam to confirm, yes, you have stroke-like symptoms, and you go straight to the ER, to the CT scanner, and they can be putting IVs while you're on the CT scanner. So it truly was a case of how many minutes can we save.
So when you arrive at the ER, as Nellie said, they're going to do a very brief intake. We're going to get a little bit of information from you. One of those things also has to do with your blood pressure. And that's another reason to be in the ambulance. Some ambulances have standing orders. So if your blood pressure is at a certain level or above a certain level, we can't give you that medication until we get your blood pressure down. And medicine takes time to work. So if the EMTs can start getting that blood pressure down for us, again, that shaves minutes off of our time to be able to give you that medication. So that's another piece of it. When you get to the ER, we're going to do things like take your blood pressure, start an IV so that we can give you some contrast to get a better picture of your brain, and then get you into that CT scanner. One of the most exciting things technologically at FMH that we've been able to get at our facility that's given us just helped so much with our stroke assessment and outcomes is that our CT scanner now there's an extra scan specific to strokes that we're able to do. So that initial scan that I talked about that's looking for that bleed that tells whether or not we can give that clot busting medication is really quick and simple. Any CT scanner can do it. It's bread and butter. There's a special scan called a perfusion scan that actually tells us where the penumbra, how much of that brain is penumbra and salvageable, and how much of it is truly dead and not salvageable. And what that does is allow us to get a sense of kind of how, whether or not it would be beneficial if you're one of the candidates for that second intervention, which is I like to call it roto-rootering. They go in, we have to ship you down to Anchorage to do this, but this is the one that has a 24-hour window. So we can give you that clot busting medication in that 4.5 hour window. We have 24 hours to get you to Anchorage if you've got a clot in a very large vessel, and they can go in, the neurosurgeons there, and roto-root that clot out and let blood flow back. But whether or not they are going to be able to do that depends on that scan. The important thing in terms of community, and I think, again, as Alaskans, we also have a very tight sense of community. We like to be in our homes and our space with our friends and family, especially if we're recovering from something. If we do that scan and find that that the brain that's been affected is not recoverable, there's no penumbra, and we can do everything for you here that they would be able to do in Anchorage. That allows you to stay here in our community with your friends and family and not have that disruption of your life and your all of that support. And to me, that's a huge part of stroke care too, because not everyone benefits from these big interventions, and we can tell that now, and we can keep you home if that's a better place for you to be. But we also know immediately that we can send you down to Anchorage to get that Roto-Rooter procedure if you're eligible for it, because we know how much of your brain is still salvageable, which is a really nice addition to our stroke sort of continuum of care. Another piece that we have in Fairbanks now that we didn't, so we have very limited specialists in this town as far as medical specialties go, and neurology is one of those. We have a fantastic neurologist that works at the hospital, Dr. Honorato, that was mentioned before, but she's only one person, and that's there at the hospital, and she's mostly retired, as one should be. So she's often bicycling across Europe or some other cool adventure like that. And in light of that, we have contracted with a telehealth agency out of Providence in Anchorage that allows us to have almost instantaneous access to stroke experts any time of the day or night within minutes of your arrival at the hospital. This cart computer thing is our telehealth cart. We can wheel that into the room, and the camera on that can get so close, can zoom in so close that when you're doing the eye exam, when your eye is tracking, and we're seeing if it's dilating and contracting appropriately, the doctor can actually measure to just millimeters how much your eye is moving and how quickly, and whether or not there are tiny micro twitches, because it's such incredible technology, and do a really good, thorough neuro exam with the help of our nurses here that are trained to assist with that, so that they can give the best possible recommendation in terms of risks and benefits of different treatments, and whether or not you should be medevaced or stay in Fairbanks or receive which medications and that kind of thing. And so that's a great addition that we have as well. Again, we've got that the tenecteplase, the TNK that we give, that clot busting medication. Just know if you do go into the hospital for signs and symptoms of stroke, even if you get there within that 3.5-hour window, not everyone is eligible for that medication. If you're already on anticoagulants, if your blood pressure remains too high and we can't get it under control in time, if you're having a bleeding stroke, there are things that will make you ineligible for that because the risk is too high. So know that as an expectation. Just because you get there in time doesn't necessarily mean that you'll get the medication, but it gives you the best chance to get in that window for that option. And then within that 24-hour window, we can medevac you for the thrombectomy, the Roto-Rooter procedure, or you'll be admitted to our ICU, and the nurses there will take care of you through the rest of your stay.
All right. So just the kudos, and then we'll open up. So we said we've been doing a lot of work. We work with American Heart Association. It's the American Stroke Association under American Heart. And all the work we did with Get With the Guidelines, which is evidence-based, top-level stroke care. In 2019, when we first started, we won the bronze award, then the silver, and for the last 3 years, we've been gold. So to your question, we've done a tremendous amount of work at the hospital. So all of this is, taking me into this slide, all of this is getting everyone to be able to recognize signs and symptoms of stroke, getting you to the hospital fast enough so that we have the best opportunity of treating the stroke, but then we are now working in the state of Alaska with the Alaska State Coalition.
So because Alaska is a huge state, and there's only the only place that you can receive that thrombectomy procedure is in Anchorage. There's been, the Alaska Stroke Coalition was started, I believe, 1.5 years ago, and what we're doing is attempting to streamline stroke care for the entire state so that everyone who needs to get to Anchorage can get there as quickly as possible for that procedure, and that everyone else is receiving the utmost and best care that they can receive at whatever point their journey stops at whatever hospital around the state. And it's improving communication, it's improving the communication between hospitals, between medevac agencies, and hospitals, between EMS and the medevac services for outlying villages. And we're doing a lot of work to collect more data on strokes in Alaska, which is part of that finding out that the age for Alaskans having strokes is so much lower and is lowering, and that we need to do work around that as well.
And then by being part of the coalition, we're also, coalitions have the right people to write grant write-ups to get us money, right? So ultimately, if we can prevent, we're going to prevent. If we can treat, we want to treat. Where we really need to keep our work is what do you do after and what kind of rehab services are offered. And if you live in Anchorage or Fairbanks, you've got a better opportunity of having some rehab services, but what if you live farther out? And so part of the coalition's job is to look at what can we do to bring more rehab to the state of Alaska, and ultimately that means how many dollars can we get? So they've been working really closely with legislature and trying to get us a little more help whenever it comes to building our rehab and coordinating rehab around the state.
Yes. And there's currently, I think, going through some process in Juneau at this point is House Bill 191. Right now, there's everybody always gets excited about trauma, and there's a lot of legislation that designates trauma. It gives it kind of a special place in the world of laws and the way that grants and things go. And the Alaska Stroke Coalition is currently working to get stroke and also STEMI, so that's the certain type of heart attack, added to that as a time-sensitive medical emergency, just like trauma, that if you need to get to help quickly to try to help streamline some of that federal grant money to the state. And so that we can collect better data, so that we can get better grants, so that we can do that rehab and or get more rehab resources, get more medevac resources. I can tell you that we received a grant that allowed FMH to participate in a kind of a more quick technology that's allowing those scans to get to the neurologist more quickly. And that's, again, cut down our treatment times by quite a bit. And that was through some of the Alaska Stroke Coalition work. So that was excellent.
And I want to say, before anybody takes off, I want everyone to remember BEFAST, remember the symptoms. Take the page home at the back.
Take a magnet.
Take plenty of magnets, stick them up on your family and your friends' refrigerator, teach them. It truly, the way you get something into the brain is, we always say, see one, do one, teach one. So you've heard one, okay? So now you need to say it out loud, and then you need to teach it, and that's going to help cement it in your brain and make it to where you will actually recognize those symptoms in yourself or a loved one or a friend.
Thank you
Thank you, guys.